So tonight's lecture will be given by Dr. Rick Tosti, who is a fellowship trained board certified orthopedic surgeon who specializes in all conditions of the hand, wrist, and elbow. He serves as an associate professor of orthopedic surgery at Thomas Jefferson University and is a consulting physician for the World Boxing Organization as well as Ultimate Fighting Championships. And Dr. Tosti sees patients at our Bensdale and Bluebell and Wynwood offices. Take it from there.
Thanks for the introduction, Natalie. So the topic we're going to be discussing today is entitled, What's New versus Tried and True in Wrist Surgery? So this is going to be a bit of a hodgepodge of different things, and I thought it was interesting now that we're coming out of COVID to touch on this experience where what was tried and true back then was wearing these big masks and these hoods, and I was actually involved in the first ever operation they had at Jefferson during the COVID pandemic, during the alpha wave, and nobody really knew what to do. But now that we're all vaccinated and we have a newer perspective, things are starting to move and life is getting back to normal again. In the outline today, I'm going to discuss certain traumatic entities such as fractures and amputations, tendinopathies, mostly focusing on a condition called Dequervain's tenosynovitis, compression neuropathies, which will be carpal and cubital tunnel syndrome, thumb CMC arthrosis, which is very common, people older than 60, and wrist arthrosis or arthritis. Okay, so beginning with the trauma section, I'm going to talk a bit about distal radius fractures. This is one of the most common fractures that I'll see and I'll treat. It actually comprises about 16% of all fractures that present to the emergency room. Tends to affect people in early in life and later in life. And there's a third spike where people in their third decade, like in their 30s, also have these due to high energy injuries, maybe car accidents, falls from height. People who are at risk for this are particularly women in the postmenopausal years and Caucasian races 2 times more than other races, mostly due to vitamin D. So what's tried and true here? This fracture was actually first described in 1814 by a physician named Abraham Colles, who said this: only one consolation remains, that the limb will in some remote period again enjoy perfect freedom in its motions and be completely exempt from pain. The deformity, however, will remain undiminished throughout life. But one thing to remember is in that description, in his time, which was in 1814, they had no anesthesia, no aseptic surgical technique. They didn't even have electric lights or x-rays. So much has changed since then, and I don't agree that every single fracture enjoys perfect freedom in its motions. Traditionally, these were treated with immobilization. So at the top is a short arm cast. At the bottom left was a pinning procedure. And at the bottom right, if you maybe remember from the mid 90s or early 2000s, these were treated with big frames, big external fixators. But they're not as good as the technology we have today. They were good for certain types of fractures. But as you can see here, there's a variety of ways the bone can break depending on the amount of energy that is imparted onto the wrist and the position of the wrist at the time that the energy strikes it. So easy fractures, which might be seen something like over here, can be treated with a little bit of traction, casting, and mobilization. But others that are higher energies, say perhaps this type 5 or type 4s or type 2s, are better treated with other technology. We have a lot of fancy measurements we use to reconstruct the anatomy of the wrist. And in general, we're just trying to make the wrist straight. And there is a controversy in who should have surgery depending on age. There is a school of thought that in people older than 60, that we should generally treat these non-operatively. However, not all fractures are the same, and not all 60-year-olds are the same either. Recently, or I should say what's new, is people older than 60 are finding we're doing very well with operative fixation in terms of getting back to life a little faster, getting back to function, particularly people who live independently or live without help. And in this study, which was published in the Journal of the AMA, had shown here, I'm going to highlight this sentence, that compared with people who received other treatments, meaning no surgery, or some of the frames or old technologies, actually had more complications. Here are two other studies showing similar things, where that people older than 60 actually do well with surgery if they're treated for the right indications. This was a case that was referred to me a couple years ago in a person who was 65, who their initial treating surgeon had told her that, well, you're older than 65 and we don't operate on cases older than 65. I mean, you can clearly see there's a fracture through the wrist, through the joint, a big deformity here. And after 6 weeks of casting, this had no chance at healing and was very painful. So this would be one that could be treated surgically with the right technology. So what's new? I think this technology is where we're using low profile plates and screws that lock into the plate to create a fixed angle device. This is helpful for bone that is softer or osteoporotic in that it'll hold the weight of the wrist. We can allow earlier mobilization, and the risk of collapse is less because you're creating a fixed angle construct with the screws locking into the plate. We also have plates that are designed for different fragments. So as we've studied certain fracture patterns, we've designed plates, as you can see here, this was treated with dual plating that will treat different parts of the fracture individually. Another thing I want to touch on is with the technology we have now with 3D printing. This was a fracture that was also referred to me. This was a gentleman who was a motorcycle enthusiast who was in a car accident, had a fractured wrist, and had this plated. Now, at first glance, this doesn't look bad. And the wrist is relatively lined up and the plate looks low profile. But what he had said to me was like, I can't turn my wrist over to grab the clutch on the motorcycle. And when I got a CT scan, what you're noticing here is this joint was still dislocated. So the ulna and the radius should be married together. And in this case, it was not, probably because the bone healed a little bit too far forward. So this was a big deal. I would have had to take the metal plate off to recut the bone and then try to recorrect it in 3 dimensions. And we thought that this would be good for some of the 3D technology that we have. So we gave a CT scan and basically pre-planned how we wanted to cut the bone, exactly where we wanted to turn it and rotate it, exactly where we wanted to put the new plate to avoid the holes from the old plate so that this bone would come into joint. During the surgery, I was printed these 3D models. So this was where we wanted the bone to be. And then I had these 3D cutting guides that we physically put in the wrist that were specifically matched to this individual's wrist. So the 3D cutting guide goes onto the bone. I can pre-drill all the holes. There's a slot here where I can make the cuts. And in the end, it turned out exactly as we wanted it, which for a complicated case like this was desirable to do this efficiently and accurately. And as you can see here, he has full rotation restored of his wrist. Here's another topic on trauma that I want to touch on, which is amputations. This was a really significant trauma. A gentleman who was struck by a train. His head's up here. This is basically, his arm was completely avulsed. On his left side, he lost the thumb and index finger. And on his right side, he lost the entire hand. And as I was looking at this with my team, we decided that hand looked pretty good, but the elbow couldn't be reattached. So what we decided to do was harvest the thumb on the right side and put it on his left hand. This is kind of what you're seeing here. So this used to be a right thumb, and now it's a left thumb. And overall, we had a pretty good outcome for this and something that would otherwise not be very functional. And we were able to publish our work in the journal Hand Surgery back in, I think this was in 2020 when this printed. So what about the ones that we can't save? What's tried and true? A lot of these are old prosthesis, hooks, hook prosthetics or mechanical prosthetics, or we have these cosmetic ones. So this is a person who lost an index finger but has a silicone prosthetic, which is not functional, but could be cosmetic. Is there anything new in this development? I think the answer is yes. This was one, unfortunately, we could not save. This was a person who worked in a heavy machinery. 3 fingers were basically pulled off of the hand and through the forearm. We tried to replant one of them and only survived about half. Still think it was worthwhile because we were able to cover the bone, but lost a lot of function from this. So basically all he was left with was a small finger and a thumb. So we did a procedure called a starfish procedure. And this was not his case, but it's called a starfish procedure because of the cadaveric dissection that was first performed, where if you take all the bones out of the hand and you look at the muscles in between, it sort of looks like a starfish. And you could actually flip those muscles backward toward the forearm, and that brings them closer to the skin. And bringing them closer to the skin and separating them gives a stronger signal to robotic hand. And that's what we did with him. This was a modified version of that, where I didn't take all 5, I only needed 2. We have 1 here and 1 here. So basically taking the muscle deep and flipping this up over top the metacarpal. And then what you're seeing here is how he's training to use the prosthetic. So the sensors are put over the muscle where I put them. And he's learning when his brain says, close my hand, that muscle fires and it activates the fingers. Those fingers can be mounted onto the plastic shell and can be used as a functional hand, as you can see here. Reasonable amount of dexterity that he would have. And this is one of the activities we gave him for training, which was picking up blocks, placing them, and release. All right, so moving on in our hodgepodge of wrist ailments, I'm going to move on to tendinopathies. So if you're a little squeamish with the ones before, rest assured they're not going to be that gory going forward. Okay, so I'm going to talk about a very common tendinopathy, which is called de Quervain's tenosynovitis. And this occurs from a tendinitis that happens on the side of the wrist. So people usually have pain with lifting. So the most common person who gets this is maybe a pregnant mother or a new grandparent, somebody who's lifting children, lifting boxes. They'll get this frictional tendinitis on the radial side of the wrist. Okay, and often we'll try non-operative things first. There's a lot of different variants for this. One of the things we'll try is, I'm going to flip through this a little bit in the interest of time, is an injection or bracing. And if the bracing and injections don't work, then we move on to surgery. But to touch on that, sort of like what's tried and true is doing the bracing and the injections. But sometimes the injection can be difficult to angle, particularly with a bigger wrist. And I think what's new is doing these ultrasound guided injections. We have this handheld technology. It can literally plug into an iPhone now. So you don't need this big device that needs to be lugged from room to room. You can plug into an iPhone, and then you can see exactly where the tendon sheath is and direct the needle into it. Okay. Surgical release is still a tried and true measure. But I would say, what's new in this respect? What's new? Not everybody has to go to sleep for an operation. So you think operation, most people get worried about anesthesia. Do I have to bother a family member to come in to bring me to the operation? And we have developed new protocols where people can actually stay awake. We call this Wallant surgery, which is an acronym that stands for wide awake, local anesthesia, no tourniquet. And a lot of advantages to this. There's no fasting, so you can have breakfast, no chaperones, you can drive yourself back and forth from the operation, no pre-admission testing. There's really no risk of the anesthesia. We can also do this for compression neuropathies. So in the hand is controlled by 3 different major nerves, the median, the radial, and ulnar nerve. And 2 of them are commonly compressed, which cause symptoms like numbness and tingling at night, numbness and tingling that can persist during the day, tingling that may exist in the fingers when you go to grab things like a steering wheel. The most common of these is carpal tunnel syndrome. And this is because if you look at the wrist in cross-section, okay, the median nerve, which is the nerve that gives you feeling to the thumb, index, middle, and half the ring finger, is the most superficial object in cross-section. So anytime you have anything putting pressure on the outside of the hand, the ligament here pushes on the nerve to a point where the nerve becomes ischemic. That's a term that we use to say the blood supply to it is not very strong, and then it begins to become dysfunctional. Okay, so I'm going to skip over a couple of these slides in the interest of time, but we can do injections for this. We start off with some braces, and if that doesn't work, then we move on to surgery. Okay, now the tried and true approach, if you knew somebody who had this procedure done in the 80s or in the 90s, they probably had a big incision. In the 80s, they actually used to admit patients in the hospital for this 10-minute procedure. But they make an incision here, and then basically you're seeing the ligament that spans over the nerve. And then the surgeon's job is to just divide this longitudinally. And what that does, it'll break the ligament apart. It'll lengthen it to the point where it won't be pushing on the nerve so much. And over time, it will reform. So what's new in this respect? This can all be done endoscopically now.
Is a demonstration.
I'm going to pull this down a little bit. But this is a video I made demonstrating how this can be done not only wide awake, but also endoscopic. So I'm going to skip through a couple of these here just so you kind of get the gist of it. But I give 3 injections in the hand and put the hand asleep. Okay. And then what we do is we make a little incision. It's only about the size of a thumbnail in the wrist. And then I have a little device here that will dilate the path for the cannula. And then this device will go in and just kind of push everything else aside. Once I do that, I can put the scope into the device and take a look around and make sure there's nothing in my way. So that's about as far as you want to go, where you see that like little fat pad, the ligaments above me. And what you're seeing is the plastic on either side of the device. And then the surgeon's job now is to pass a small endoscopic blade through to divide the ligament without having that big incision. So I'm going to fast forward that here so you can kind of see how that works. So this is the blade that goes and divides the ligament all the way to the end. In this case, I'm doing this wide awake with no tourniquet so the patient is comfortable. All right, so moving on. The next condition I want to describe around the wrist is called thumb CMC arthrosis. You may hear the term arthritis, and we use them interchangeably in casual conversation. But the technical term for it is arthrosis, which means degenerative condition or wear and tear. Okay, this is the most common form of arthritis that's indicated for surgery. Okay, it's the second most common form of arthritis overall. Tend to see it more in women than in men, and the reason is because the estrogens in women make the joint more lax, so the joint may have more play to it. Usually the joint in women is a little bit more shallow, so it may wear faster for those reasons. So up to about 25% of women will be affected by this at some point in their life, and about 8% of men. Okay. Here's a dissection of the joint. So if you follow the thumb all the way down to the base of your hand where it meets your wrist, this is about where this dissection exists. So the base of the thumb metacarpal comes down to here, and there's certain ligaments that keep it stable. And what happens is when you have the arthritis is all the cartilage between these two surfaces begins to wear down, and the bone begins to grind on each other, and that's when it starts to hurt. So cartilage doesn't have nerves into it, but bones do. So when bone starts to contact bone is when it starts to become painful, and it may look crooked or deformed as well, because as you wear down one surface respective to the other, the thumb will start to shift. Okay. This is a biomechanical slide sort of showing you how stability works on the thumb. I'm going to skip over this and show you this x-ray here, which shows you what this looks like when you have bone-to-bone contact. So what I always tell patients in the office is take a look at the other joints here in the wrist. Okay. If you run your eye along, say this joint here, you see there's a nice smooth black space, and that still represents your cartilage. And even under here, nice black space here, good space here, which means the cartilage is all still intact. But if your eye draws toward where the thumb meets the wrist, you can see here that there's no space left. And this looks very dense with bone. And you have these big jagged edges to it. These are bone spurs. And you have these little things floating around in the joint. These are called loose bodies, which are basically cartilage that's been chipped off and is floating around. And all this causes pain. So we can treat this non-surgically. About 70% of these can possibly avoid surgery with the use of the splint. Sometimes we'll do like Advil or Motrin. Sometimes we'll do injections if that doesn't work. But ultimately, if none of that works, then we indicate people for an operation. Now, what's tried and true? There was a study that was done by the National Hand Society in the early 2000s that asked surgeons, what is your preferred method of technique? And this was actually the most common way that hand surgeons still do the procedure. So what they do is they remove the arthritic bone, and then in its place, take one of the tendons out of the forearm, weave it through the bone, and then weave it to the anchovy shape, and then leave that anchovy shape in the place of where the bone was. Okay, so remember, you had one bone here and one bone here. I've taken this bone out, and I'm replacing it with your tendon. And this procedure was described in 1986. Still very tried and true. Not many things in medicine have that kind of longevity. Okay, this is kind of a cadaver demonstration of that surgery. So you can see 4 incisions, and basically what you do is you take the tendon here, okay, and then you have to follow it all the way up the forearm, And then in the classical description, they only took half the tendon. So you have to cut half of it, then you trace it all the way back to where it was. And I'm going to skip ahead here just so you can kind of see. Okay, we make a drill hole in the thumb, and then the tendon gets woven through the bone and then back onto itself. So you can see here a lot of surgery, 4 incisions. One of them is very big, and there is a little bit of downside to having to take a tendon. So if you look at the current literature, there's about 16 or 18 different acceptable ways of doing this operation. And the one thing they all have in common is you just need to remove the arthritic bone. So I said to myself, what is the least invasive way I can possibly do this? And we developed this technique, which is doing this all arthroscopically. So compare this to before, where you had 4 incisions, one of them very large. Basically, all I'm making is 2 little poke holes. I'm going in the joint here. So now I'm looking at the joint. This is cartilage here because I'm off to the side. But as I come to the front of the joint, you can see all this yellow stuff here. That's all bone to bone. Make a little poke hole in the thumb here, and I have a tool that goes in to dissolve. It's a little bit of dexterity for me. I call it my one-man band procedure, where I'm kind of operating each pedal with each foot. And then what we do is we just dissolve this, this bone out until we create the space. I go back in with the scope and I make sure I got all the loose pieces. So what I'm seeing here is the edge of that tendon, which I don't have to sacrifice or take. I'm sparing it. Okay, this is like what's remaining of the bone up here, this little chunk here. So I'm going to take that out. And then what I'm left with is the 2 bones that I'm supposed to keep and remain, and they're nice and clean. This is an example of a patient who had both procedures. She had the open procedure on one side and the arthroscopic procedure on the other side. And she's explaining to me how she perceived the difference. So I said, what do you think of the 2 procedures? And here's her answer. Okay, so it's about 6 weeks on the left side, arthroscopic, right?
Yes.
And on the right side, you had the traditional open.
Yeah.
So just summarize for me again, just to compare how the pain was after each procedure.
The pain was much worse in the right hand procedure. It lasted much longer. The PT was much more difficult to handle. It was much more painful to do, and it took much longer for the PT to work, to really be able to do everything. The left hand, less painful recovery, less pain in the PT, gain strength
Scars
better.
Just this one and this one is your scar.
Yes.
And on the opposite side.
Can you see it?
Yeah.
There it is.
Yeah.
And then I had, the pin thing that was bothering me, but it doesn't.
So you think big difference between the 2 procedures?
But 2 different universes. Yeah.
Okay, so as you can see, the patient perception of the less invasive version is significant. All right, and then this brings me to total wrist arthritis. So before we were sort of focusing on the base of the thumb down here, and now the question is what to do if somebody has arthritis throughout the entire wrist. Okay, so this is the radius bone, this is the ulna, these are the 8 bones that make up the carpus or the wrist. And as you can see, significant wear here. So remember what we learned is that if you see space between 2 bones, that's good. That means the cartilage is still there. In this case, you can see no space. If anything, the bone is starting to carve a little divot into the bone here. These 2 bones are actually separated. So this one and this one should be next to each other, and they're actually splayed out. And the one above it is starting to push in between. So this one should be all the way up here, and it's pushing in between the gap. So there's arthritis along the entire wrist. This can be painful with wrist range of motion, with gripping and lifting things, okay? And again, like everything in orthopedics, we try to start off with non-operative solutions first, okay? We may start off with some activity modifications, may start off with some bracing. Sometimes we'll use some injections. The injection usually goes into this area here. But if none of that works, then again, we have a surgical option. And the tried and true version for this is using a plate or some other device to fuse the wrist together. Okay, so basically what you're doing is you're turning these few bones into one bone. You're trying to have one bone from the radius across the wrist and then into the third metacarpal, turning into one bone. You're fusing them together. And you may ask, why would you do that? And the reason for that is because if you put them all together in one bone, there's no motion. If there's no motion, there's no pain. So it's a procedure to reduce pain, but the negative is you can't move your wrist anymore. So what's new? I think this is what's new, and this is up and coming. We have replacements in the wrist, just like we have replacements for knees and hips for people who want to preserve motion. Okay, now this gentleman here to my right is a left-handed person, and a wrist fusion in a left-handed person is very difficult to write. If you ever seen a lefty write, they really curl their hand around to kind of get that leading edge. So this is something he desperately did not want, was a fusion, and we went with a wrist replacement for him. Now this is what the device looks like on the left. This is the newest version. Most people would consider these in 4 generations, and this is considered a 4th generation design. And on the right side here, I have planted this about 6 months prior. And I'm having him just kind of make a writing sample for me here. So he's showing me how he can write. And then I'm going to fast forward this here just so you can kind of see how he starts moving the wrist. And just show me how you can move your wrist around. Yep. Almost normal range of motion, compared to a fusion where we had none of that, no range of motion. So some advantages to preserving motion for sure. Okay, so with that said, I know I covered a lot of topics. Some of this was in some detail, and I hope for an audience such as yourselves, this wasn't too big of a bite, but my advice to my medical students is it's never too big of a bite, so take it. And at that, if you have any questions, I'm happy to answer those in the chat or those you may have.
Thanks, Dr. Tosti. No questions listed as of yet. If anybody has any.
Connecting to the internet.
About that. I do have one question actually. Is there anything that you can do prior to hand or wrist surgery to improve your surgical outcome, Dr. Tosti? I guess it maybe depends on the issue, but is there anything that could be done prior?
Yeah, I mean, in general, you want to keep the joints supple and you want to keep your strength. So for most people, their preoperative range of motion is usually the biggest predictor of their postoperative range of motion. So if you're in pain or you're getting stiff, I tell people to continue to use the hand, try to continue to use it for normal tasks. You can do stretching, things like that to continue to have good range of motion and continue to have good strength.
Awesome.
We had one in the Q&A here. I see one here. Okay. Do you see that, Natalie? Or,
Yes.
Okay. So sure, I'll read this one. That's I was just talking about this earlier. It says, can CMC arthrosis be caused after a foosh, which is a fallen outstretched hand, if you've ever had pain there before? So that, yes, the short answer is yes. So I would classify this into 2 different categories. Okay, one is somebody who fell on the hand and fractured the hand. And if the fracture didn't heal well, meaning like if for whatever reason the fragments weren't lined up well, that can cause arthritis very quickly in a very accelerated fashion. So for fractures that have incongruity, we will make sure that we line it up to prevent that. That's one category. The other category is people who have arthritis or arthrosis in the base of the thumb, and it's not very symptomatic. Maybe you don't notice it, and then you fall on it, and now all of a sudden it's symptomatic, and it's really hard to switch that off. So the short answer is yes. And sometimes, I get this a lot, like, well, I never had a problem before the fall, and you might not have. It might have been fine and asymptomatic, and the fall just tipped it over the edge, for whatever reason. Maybe there was a little bit of cartilage left that chipped off. Maybe just having the bone-on-bone impact was just too much for the joint to take. And now it becomes a symptomatic thing where we have to provide some strategies. Okay, so I have one question here. Yep, okay. And then, yep, thanks for your comment, Eileen. We'll see you soon. And then Tracy had asked, what would you do for frayed carpi ulnaris? So I'm assuming you mean extensor carpi ulnaris. There's a flexor carpi ulnaris too. I've had a few therapy sessions which have helped, but usually breaks down after a while. Okay. Yep, extensor. Yeah, I figured that's what you meant. Okay, so the extensor carpi ulnaris tendon is a tendon that runs on this side of the wrist right here. It runs in a little tunnel on the wrist, and its job is to extend your wrist and to what we call ulnar deviate your wrist, almost like a karate chop kind of motion. And it hurts in some people with certain activities, particularly people who are doing repetitive stress that involve wrist extension or deviation. If over time you have a tendonitis that is just continually inflamed, sometimes it can develop into this frayed pattern, which in your case, it sounds like you have. So an MRI can usually diagnose that, where inside the tunnel, the tendon itself doesn't have a good signal, and you can tell those multiple tears in it. So the inflammation has been so much, and the wear on the tendon is to a point where it's like a rope that's starting to kind of break and unravel, but it hasn't broken yet. That's what a frayed tendon is like. So how do we treat that? Well, you're right. Initially, we'll start off with some therapy, which involves stretching, range of motion, and bracing. If that's not successful, we can try some injections into that region to see if the pain will go away. Now, that doesn't help with the fraying, but it may help with the pain. And if the pain goes away, then the fraying doesn't matter anymore. And then last, if nothing conservative has helped, then we move on to surgical management, which is not a big procedure. I mean, we make a little incision here along that side of the wrist, expose the tendon. So part of the problem is the tendon's too constrained in the tunnel. So we release the tunnel, so there's nothing rubbing on it any longer. Okay, and then usually there's a whole bunch of inflamed tissue on top of it. We remove all that, and then I'll take a suture and usually kind of spiral the tendon back together to try to congeal all those little tears. So it'll make it a little bit more reinforced, and usually that does the trick. Any other questions? You're welcome. Okay. You're welcome, Linda. Thanks for commenting, and thanks for hanging out with us tonight.
Anyone else have any other questions? We'll wait a second. I did put my email in the chat box. If anyone thinks of a question, after we log off, I'm sure Dr. Tosti would be happy to answer at a later time. You can email me directly. You can email me directly as well and reach out if you are interested in setting up an appointment with Dr. Tosti, and I'll be happy to get you set up.
Okay, great. Well, thanks everybody for the privilege of speaking with you. And if you feel like it would help to have a consultation, then please contact us at the Rothman Orthopedic Institute. Thank you for your time.
Thanks, Dr. Tosti. Everyone have a great night.